Hello and welcome to PHM 627. For this course, we'll be discussing evaluating through access. So we have a couple of learning objectives. First is to describe what access is and look at some of the dimensions that are used to evaluate healthcare access. We're also going to look at barriers to access, focusing on availability, affordability, and acceptability. And then finally, we're going to describe what the health factor module is and what role it plays in evaluating true access. So, starting with healthcare access. So, one of the ways that we look at access is in terms of one's ability to obtain healthcare services. This is whether you're looking at it in terms of preventive services, diagnostic services, treatment, management of illness, just a peripheral way of looking at service is just from the are you able to obtain healthcare service? Yes, no. So that is one way to look at service, but this does not completely give the best picture of how service actually does get, in effect, how that looks like. So in order to fully understand it, we have to ask the question of who needs the service and how they're using the service. So who needs the service who needs to use the service are some of the two key questions to ask in terms of fully understanding what access is. And access is the freedom to use healthcare services, and it does not necessarily mean the services are indeed used. So you have the freedom to use it. Like there's nothing that says you can't use the services. However, whether or not you use the services is an entirely different conversation on its own. So that is access and that is utilization. Access and utilization go hand in hand. Without access, the conversation of utilization doesn't even come up. However, we have to understand what access is and how do we fully understand what that looks like in real time. So, and to be able to understand that, we have to ask the question or evaluate what is called degree of fit. So, with degree of fit, we are looking at what is the healthcare system and how does it interact with the individuals or households within the healthcare system. Is the healthcare system designed to meet the healthcare needs of the individuals or households? So that's how we think about when we think about access. So there's access, and then there is true access. True access is more comprehensive in terms of trying to make sense of what access is. With true access, you're also considering things like: are you able to get to the healthcare clinic? Are you able to, once you get there, are you able to come back from it in order to do what you need to do? And it's also looking at whether one has an ability to pay for the services that they need, with the emphasis being on the services that they need. And then after you've paid for the service, the needs, the services that you do get, do they actually meet your needs? So just because you're able to pay for the services does not automatically equate to the services that you get being able to meet your needs. So getting your needs met once you enter the healthcare system is a very important component of understanding access. So an example would be: do you have the transportation to get to the clinic that you need? If you have transportation, but the time that you need to take to go to the clinic means that you're going to take time off work, and the time that you take off work, you're not going to be paid for it. That is something to consider, in addition to considering whether you're able to pay for the services itself. So in this picture, we kind of see, especially at the total, the bar that has the total, it looks like from the poorest to the richest, that they are all having equal treatment in healthcare service. However, but when we consider use and needs, we see that it's really not the same. For instance, you have the needs of the those in the richest being smaller than their use. So their use of healthcare services exceed what their need is. And then on this other hand, we have the needs of the poorest being greater than their need for it. So we need to basically understand access by breaking it down into few factors. With this image, we're kind of looking at socioeconomic factors. So you can watch this video that looks at access from the medicine part of it in terms of being able to get medications. And this looks at it from a global health perspective rather than just individual countries. So it's a very important video to watch. So now let's talk about barriers to access. So this is some of the dimensions that we use to evaluate what access is. We have availability, accessibility, accommodation, affordability, and acceptability. However, for this class, we are going to only focus on availability, acceptability, and affordability. With availability, we are kind of looking at what's your one access, physical access. There is a clinic, can you get to there? Or is there a clinic to begin with? So those are the kind of availability that we look at when we're thinking in terms of access. Then with acceptability, we are looking in terms of cultural competence. If you get to the clinic, is there going to be translation services for those who do not speak the majority language that is in the place? Or are you going to have some challenges explaining to the healthcare providers what you mean when you are describing your symptoms? So those are all the things that come into acceptability. And then with affordability, we're kind of looking at it from financial access, the ability to pay, basically. So with availability, we are looking at what is the relationship between the location of the healthcare facility to the location of those who need the service, and also transportation options. So I often use this example, sorry, especially as it regards to Hammond. So Hammond does not appear to have a public system, which means that if you need to go to a physical location of a clinic, you either have to drive yourself or you be able to afford paying for transportation. Everybody does not have a car, or everybody cannot afford to transport themselves because usually it costs more, and you may not be able to have friends that can take you to where you need to be. So that becomes a problem. In the way that Hammond as a place is set up, it's not ideally set up to make use of healthcare facilities to be available, just because of having that problem of transportation options being very limited as it is. So sometimes healthcare providers do provide transportation resources. I'm not sure whether it happens here in Hammond, but when I used to live in St. Louis, they had some of the clinics had transportation that they do go. You can sign up for it or you can request it, and they can come to a stop, and people who need it get to enter. And sometimes you have the buses just going through the city, and those who then need the services get to use it. So you do have some healthcare providers that make arrangements for transportations for the people who need it. So I'm not sure if that's how it is in Hammond, and so that's one of the things to consider. Also, also the healthcare providers being willing to have various options in terms of the services. If it is a provider that only has one way of providing care, meaning you always have to come to the clinic, that limits its availability. But if it's a provider that has options of mobile services or can do home visits, especially if the home visits are not coming at an extra cost, then it's become more available. So, with degree of faith, also considers the hours. So, if ideally you want to have healthcare providers that have a more flexible time that can see patients early in the morning or late in the evening, because if the patients only can see clinicians within working hours, that is 8 a.m. to 5 p.m. Some people are going to be at work and will not be able to take time off from work in order to see the clinician. So, degree of faith also has to consider the working hours of the population in order to sometimes make some provisions for those who cannot, use the service within peak hours. And also, we have to consider things like the relationship between the type and the range of services provided, the quantity and quality of the service provided, and the nature and extent to which the health meets that of the population. So you don't want a situation whereby, let me use for example, a large cosmetic surgery station being situated, for instance, in a rural community. There's not going to be a lot of people from that community that are going to need cosmetic surgery, especially because insurance doesn't cover it, and so you have to pay out of pocket. So that facility is not going to meet the health needs of the community. So that's one of the things to consider. You also don't want to have a provider that has, going to charge a lot of money for a service in a place where most people cannot afford that cost. So that's something to also bear in mind. With affordability, degree of fit here is looking in terms of what is the cost of using the service compared to one's ability to pay. Now, there would always be people who are going to be able to pay, whether paying out of pocket or having a very good insurance that is able to cover it. So we have to look at what is the proportion of people who do not have the ability to pay. So it's not because some people can pay for it doesn't mean it's affordable. Just question of how many people can pay for it. So you need to describe people's financial access to healthcare service in the broadest possible sense, which is, like I said, some people would always be able to pay, but just because some people are able to pay does not mean everybody is able to pay. So to get a true sense of affordability, we have to look at it from a broader perspective. So, but there needs to be some kind of arrangement in the healthcare provider in terms of thinking, payments, sustainability for the provider to be able to be in business and also for the patients who need it to be able to get the service. So there needs to be that conversation. How are we able to meet the needs of those who may not entirely be have the ability to pay while not going out of business? So there's some of the conversation that needs to be made around affordability. So with acceptability, we are kind of looking at the nature of the services that are being provided and particularly how it is being perceived by the individuals and communities that the services are being provided for. So here, the degree of faith is looking in terms of what is the attitude of the provider, what is the attitude of the individuals, and a lot of conversations about attitude is very much contextual in the sense that it is influenced by factors such as age, sex, ethnicity, language, cultural beliefs, what the socioeconomic status is. So, and you have providers having their own expectations and patients having their own expectations. And sometimes these expectations do not match. So you may have a provider having expectations of patients to respect their professional status and comply with the prescribed treatment, and especially to an extent for which is going to work for the patient. But patients may have a completely different expectation of providers. It may mean that they want to be treated respectfully. Remember, this is very subjective. So the provider may think wholeheartedly that they are treating this patient respectfully, but that's not how the patient is perceiving it. So that's something to consider. They also want to be listened attentively to their symptoms. Again, this is very subjective and can be have a lot of cultural context to it. In some cultures, there may be a particular way people behave to show that they are listening, and in some other cultures, it's different. In my culture, if someone is listening to you, they need to do things like, sort of intermediately indicates that I'm hearing you. If you're not saying anything, the person who is talking to you feels like you are not listening. So a lot of that can happen. It also, like I said, is very subjective. So just because how the provider may be behaving may not fit in with what the patient is perceiving it to be. And of course, he wants the patient, the provider, to take a thorough examination, which also can be subjective. You may have patients that are insisting that something is wrong and they are saying, look through. And the provider may feel in their own professional capacity that there's nothing that is going on. You are all good. This patient is going to leave feeling that they haven't had thorough examination. However, the provider may go ahead feeling that the patient doesn't trust their expertise. So, like I said, it's very, very contextual. And then a patient also have an expectation to be able to explain their illness and discuss treatment alternatives, especially to the extent that the provider and the patient feel that these expectations have been met. So you can watch this video that kind of looks at access to healthcare, especially from the angle of affordability. It's a very nice video, so very, very helpful in understanding it. So we cannot talk about access without talking about equity in healthcare use. With equity, we need to consider things like who is using the services, who needs the services. In terms of utilization, you're thinking about, is the use of the services being distributed according to need or ability to pay, whereby if you can't pay for it, you don't get the services regardless of whether you need it or not. And then you also have to consider who pays for the healthcare service and what's contributing to the health system's ability to pay. Some health systems are not built around improving people's ability to pay. Some healthcare systems require you to make payment upfront before you can get any kind of care, meaning if you don't have money at that particular moment, you will not be able to get any kind of healthcare service, which is a challenge because problems with health are not going to ask you ahead of time whether you have money to pay. It's just going to come, and sometimes it comes at a time that's inconvenient. You've already spent a lot of money on other things, and then suddenly you are ill. So imagine if that's the situation that you kind of experience, and you can't use the healthcare service because you're being expected to pay at the point of service. So that is something to consider in terms of looking at equity in healthcare use. And this also, you have to look at it in terms of socioeconomic group, where you're also looking at ethnic groups and we talked about catastrophic spending, where you're also looking at what is the percentage of the household income is going into healthcare financing. So these are all the things to consider when we are considering equity in healthcare use. So there are two ways of looking at equity. We have horizontal equity. In this case, we are looking at those who have the same need, should be able to benefit or receive the same treatment. You shouldn't have to give a different kind of treatment based off on people's ability to pay, meaning if you can pay for the service, you get a bigger or a better quality of service compared to the person who is not able to pay. So that is, when we consider horizontal equity. With vertical equity, it is in terms of those with different abilities to pay, should make appropriate dissimilar payments for healthcare services, in the sense that if you can pay for the services, you should pay for the services. If you have the ability to pay, you should pay for the healthcare services in order to offset the services for those who are not able to pay, such that they are able to receive some form of welfare gaps that make it able for them to pay. So that is what we call vertical equity. If you have differential ability to pay, it should not determine the, lead to differential use of service as a result. So that's where that comes in. So with vertical equity, we are looking at progressivity, and that is the extent to which one, with those with unequal ability to pay differentially for healthcare. We're also looking at payments on average, where the rich contribute more as a proportion of their income compared to the poor. If you have a situation whereby everybody pays a flat payment, that is not equity, because one person can make this payment and it's not going to, impact their life so much. And one person makes this payment and they're not able to pay rent as a result. So you have to consider that when having conversations about vertical equity. So this image looks at barriers to access. It has the supply side of it. With the supply, we're kind of looking at it from the healthcare provider perspective, and then it has the demand side of it, which is from the patients are part of it. So geographical location could be one of those barriers that come from provider, while demand side could be indirect cost of household in terms of transportation to go and how much it's going to cost. Affordability could be looking at costs and prices of services, while household from the barrier side is household resources and willingness to pay. Now, willingness to pay is not the same as ability to pay. Some people may have the ability to pay for a service, but they may not be willing to pay for it. It's a matter of deciding, this is what I would rather pay for versus the other, which is where, opportunity cost comes in, that really looks at that. So this is some of the things to look into when we are having conversations about barriers to access. So also watching this video will help you to understand economics to equity from healthcare. It really, really deals with this. Very good video. So lastly, we're going to talk about the 8-factor module. So the 8-factor module tries to assess the strengths and weaknesses of a healthcare service in a country. It is used to demonstrate whether a healthcare system is actually providing true access, or if it's going to look at, that image where I showed you when we looked at the total, everything looks equal, but by the time you compare use and needs, you start seeing the inequality there. So you use the 8-factor module to look at that as well. So what this module does is it evaluates a comparative descriptions of how the healthcare service is doing, not just nationally, but globally. It tries to really look at that, and it's a more thorough and critical analysis of each country's healthcare system. And it identifies some of the weaknesses and strengths that exist in one system and what it could learn from another healthcare system. So this is the 8-factor. You have historical, you have structure, you have financing, interventional, preventive, resources, and major health issues and health disparities. So to get a full sense of true access in this healthcare system, you have to look at all of these different pockets to get a good sense of what's going on in the healthcare system. So the key is showing solid direction, showing a factor that's depicts the core codepit of the system that demonstrate evidence supporting whether this provides true service or not. Right. So historical, there are a couple of things that we could be looking at in terms of historical. One is, how healthcare system in that country emerged. How was it historically, and how did it move from where it used to be to where it is now? So it kind of explores how health access is being used. Also, in terms of what was the countries or communities' understanding of what health is, how were health services being offered before, things like that. It does help in explaining some things. And then we have structure, how healthcare delivery in the country is organized, looking at healthcare system, health policies, interdisciplinary roles and responsibilities, staffing patterns and needs, related outcomes. What are the presence of structural barriers that exist and may prevent or impede access, such as the location of services, the government policies and procedures, and what the health policies and legislations are like. With financing, a couple of things we're looking at, including where the health budget goes. Just because it's earmarked for health does not necessarily mean everything goes into everything. Some health financing will go more into secondary and tertiary care than to primary care. Such healthcare system is not going to have the same outcomes as a healthcare system where a lot of its health financing is going into primary care or preventative care. So something very important to look at, and also looking at the government's role in administering and overseeing health care. With interventions, we are looking at delivery focus, primary care, acute care, restorative care, primary care. What is their health promotion like? What is a disease prevention like? Cure and care, also looking at care outcomes as evidenced. So you need to, find evidence to show that some of the things that there's being done actually has the health outcome that is being desired. Then prevention is looking at the extent to which the system is preventing disease by maintaining and preserving physical, emotional, and mental health of the people. You can look at the domain of primary care. As you know, primary care is primarily focused on disease prevention and health promotion. And so just have a look at this. It kind of explains a lot about what is that. And then with resources, we are evaluating the availability of adequate human, social, and spiritual resources. Is also looking at advancements in technology. Then major health issues, we are looking at things like burden of diseases, looking at incidences and prevalence of diseases, chronic conditions, what is the proportion of vulnerable populations, and how are people coping regarding the level of independence or dependence in carrying out their daily task. For example, there's very high suicide rate in Lesotho, Korea, and Japan, which is going to have impacts on their health outcomes and their healthcare system. So finally, with health disparities, we are looking at health inequities. We're also looking at try to identify the three diseases that really affects the population as it relates to social determinants of health, and we can look at it in terms of income, in terms of age, and in terms of race. So this video looks at asking a couple of global health experts to talk about what they consider to be the world's best healthcare system. And in this video, it's a short video, they really did discuss the pros and cons of each different healthcare system. There is no healthcare system that has it all together and everything is all kumbaya and everything is going well. So it's a very interesting video to watch in terms of understanding how that kind of works out. So this is where we end for today's class. As always, do use the Q&A board if you have any question. Do have a lovely day. Bye.